Good morning and welcome, everyone. So it's my pleasure this morning to introduce Dr. Stephan Fihn to speak. Dr. Fihn is a UW professor in the Departments of Medicine and Health Services, as well as the head of the Division of General Internal Medicine here at the University of Washington, a position he's held since 1995. He received his medical training at St. Louis University and completed residency, including a chief residency here at the University of Washington. And he was a Robert Wood Johnson Clinical Scholar and earned a master's degree in public health also here at the University of Washington. So Dr. Fihn has spent 36 years with the U.S. Department of Veterans Affairs, providing both primary and hospital care to our veterans. He directed one of the first primary care clinics at the VA Puget Sound, as well as the Northwest VA Health Services Research and Development Center of Excellence. His own research has addressed a broad range of topics, but relevant to his talk today, he has investigated strategies to improve the efficiency and quality of both primary and specialty medical care. In 2002, he received the Department of Veteran Affairs Undersecretary's Award for his outstanding contributions in health services research for this work. So please join me in welcoming Dr. Stephan Fihn as he presents a measured perspective on performance measurement.
Can everyone hear me? I want to express my gratitude to the hardy souls who braved the ice to come. I'm going to assume it's the weather and not the topic that accounts for the sparse crowd. The topic is one I think that's not the sexiest, but it's one that affects us all in many ways in medicine and elsewhere. So I'm going to talk about performance measurement. I'm going to give a bit of background about sort of the evolution of thinking about performance measures and discuss the rationale for using performance measurement in healthcare, and then discuss some of the pitfalls and ways in which we can think about ways to apply performance measurement in a thoughtful manner. I'm going to start with a quote from the New England Journal of Medicine from Beth McGlynn and Eve Kerr, that current performance measures are burdensome, expensive, inaccurate, and indifferent to the complexity of care delivery, a rousing endorsement of performance measurement. As we go back and review the history, I'm going to start with Robert Lowe, but not this Robert Lowe, this Robert Lowe, who was the first Viscount of Sherbrooke and the Home Secretary and Chancellor of the Exchequer in England. And Parliament was concerned about the rising costs of education, and the Prime Minister deputized him to develop a strategy for containing the costs of education. And he devised a plan called payment by results. Sounds familiar, right? And the way in which it worked is a school would get 4 shillings per pupil if the pupil showed up for class, and they'd get an additional 8 shillings if the pupil passed reading, writing, and arithmetic. And the complaint about the system was that the schools spent all of their time preparing for the visits from Her Majesty's inspectors. And one of those inspectors was Matthew Arnold, the famous English poet. And he thought the system was quite wrong-headed, and because he thought that the desire and ability to read intelligently could not be measured by basic tests. And ultimately, the system failed, and Gladstone pronounced that Lowe had been wretchedly deficient in this task, and most historians to this day agree with that. Another one of the milestones is this fellow, Frederick Winslow Taylor, who is probably the father of modern industrial engineering. And he spent his career in the automotive industry trying to develop efficient ways for factory workers to produce cars. And his work has been termed the scientific management was his approach. And I'll just read one quote from his book, which I think is telling. It's only through enforced standardization of methods, enforced adoption of the best implements and working conditions, and enforced cooperation, I love that term, that this faster work can be assured. And the duty of enforcing the adoption of standards and enforcing this cooperation rests with management alone, and the italics are mine. But this system was credited with reviving the auto industry, which had been somewhat depressed, and was widely adopted and resulted in a very robust industry during the 50s and 60s, which later that system led to some of the serious problems in the automotive industry, which we won't discuss. But again, the success in the automotive industry led to its being adopted more widely in society. There was another adoption within the system, bonuses for test scores. And just as a digression, I would mention another individual who was his contemporary, Frank Gilbreth, who really was the father of modern ergonomics, and also worked largely in the steel industry and other industries, where Taylor, mainly his main instrument was a stopwatch in sort of figuring out how fast people could do their work. Gilbreth really spent time observing the workers and trying to improve how they did their work, and was concerned with their welfare and safety as well as the efficiency with the industry. And Gilbreth, you probably don't recognize here, but he also had a very large family, which, if you're familiar with this movie, is actually based on part of the life of Frank Gilbreth. Related to the success of Taylor's system in the automotive industry, Bob McNamara, who went to work for Ford after World War II and rose actually to becoming president of Ford, was well versed in these methods, and was appointed by John Kennedy shortly after the election to be the Secretary of Defense. He'd only been president of Ford for actually, I think, a few months when he got appointed. And he brought the lessons he'd made at Ford and took them seriously, and during the Vietnam War developed a whole set of metrics by which the success of the campaign could be measured, and came to the conclusion, based on mortality rates among the soldiers, that actually if we could maintain the ratio of U.S. deaths to Viet Cong deaths, that we would win the war by attrition. And so he developed these whole sets of measures which all the officers in the overseas in Vietnam had to report on a daily basis back to the Department of Defense. And we know ultimately how well that turned out. And gave rise actually to something that's now known as McNamara's fallacy, which is basing decisions solely upon quantitative measures and ignoring everything else because it can't be measured easily or proven. So that brings us to the issue of why should we use performance metrics in healthcare? And there's several rationales for doing this. The initial rationale was to support system improvement. You can't improve a system unless you can objectively measure it and understand if actions you're taking do result in improvements. And the thinking is that by doing this, you can accelerate the uptake of evidence-based practices, you can reduce variation, and thereby reduce low-value care. Over time, performance metrics have taken on other roles. One is to provide an objective basis for accountability, so we can look at health systems and providers, and are thought to give a standardization of our metrics and transparency as to how our systems are working. They're thought to promote organizational learning and to support incentive systems using rewards and competitions. And this is back to our pay for performance, which is very widely, almost universally applied in healthcare these days. Performance metrics are also used to inform patients. They can look up metrics on public websites or doctors to figure out, to make informed choices, and through all these mechanisms to overall promote high-value care. So I'm going to briefly, and not exhaustively, but look at the evidence for each one of these claims. First, however, we just have to recognize that one of the other driving factors here is technology. There's just, as we all know, massive proliferation of data. Every system now generates huge amounts of data that comes from providers like ourselves, but also machines, monitors. Everything is generating data. Patients are contributing data through websites and mobile apps, and we're also tapping into external databases about health, insurance, claims, etc. The technology now facilitates very efficient storage and retrieval of these data, and there are just stunningly effective databases and management tools. So I spent 6 years as the director of analytics and business intelligence in the Department of Veteran Affairs, and the data that we had, and this was starting in 2010, so almost a decade ago, was really stunning for the time. You can see that we were getting, millions and millions of new data entered into our system every single day, and that we had nearly 1 trillion rows of data in SQL tables. The analysts in my office, I had 150 analysts who were routinely manipulating tables that might have 2 or 3 billion rows and 10 or 20,000 columns. So the amount of data that is available really, and the fact that computers can readily manipulate these data is a real driving factor. So if we go back to sort of the early days of performance metrics in healthcare, and the VA was one of the first adopters of performance measurement, beginning in the mid-90s. And this was in response to actually severe criticism that the system was very ineffective. Congress was in a mood, actually, and this will sound familiar, to privatize the VA. And even the National Academy of Sciences published a report that supported that approach. The VA was sort of given one last chance, and a undersecretary by the name of Ken Kaiser came in and made a lot of changes, and one of them was the introduction of performance measurement and quality improvement. And they began in '96 with 10 manual measures. These were gathered by abstractors with our old paper records prior to the widespread advent of the electronic health record. And these were linked to the ratings of the senior executives at each of the medical centers, and really were focused on local QI measures. And they used what was there sort of the early HEDIS measures. And this is just one example here, a prevention index, which is a composite of multiple metrics, which many of us in primary care are familiar with. The PSA screening counseling one sort of is gone by the way, but the others are still in one form or another quite appropriate. And you can see here that at the beginning of this effort, around '96, the scores for the entire VA system were around 35% for this metric. And what's also, apparent is that over a really short time, 3 to 4 years, you can see that more than doubled up to about 80%. And over the next couple of years, went to 90% and then plateaued. And those measures have been at that same level pretty much for the last decade and really haven't changed much. The same was true of a chronic care index that rose from 35 to 80% in 3 years. And this really had, I think, a lot to do with the VA's improvement, was the application of these measures to improve care. If you look at other systems of care, on the left here is the National Health Service in England. So you can see around about the same time, they were doing a little better. These are different metrics. They're metrics for asthma, coronary disease, and diabetes. But you can see over a relatively few number of years, there was a fairly steep improvement in the metrics, and then they plateaued out. And Kaiser Permanente, the same. You can see they started, this is hypertension measurement in Kaiser on the right, starting around 45%, and over a period of 5 years getting up to close to 80%, where it's stayed flat. So this seems to be a sort of reproducible phenomenon that comes with the introduction of performance metrics, particularly for these types of clinical processes. So I think, you know, we can say they do appear to promote system improvement, which was the initial rationale for application of performance metrics. And in fact, there are lots of other examples than these. You know, and all of us in each of our specialties can probably cite some instances where we know that performance metrics have made a difference. But if you look in central line associated bloodstream infections, surgical site infections, venous thromboembolism prophylaxis, all of those metrics across most health systems in the nation have improved. And that improvement has really been closely tied to specific kinds of improved processes. So in the ICU, for instance, bundles for line insertion, for ventilator management, for infection control, that by implementing those specific processes, you can show that these metrics actually improve. Other examples, the VA did this in surgery with their National Surgical Quality Improvement Program, which has now been adopted nationally as NSQIP. Decontamination for preventing MRSA, the AHA-ACC guidelines program, particularly with an emphasis on door-to-balloon times for primary PCI, reductions in catheter-associated UTIs, and antimicrobial stewardship programs. And I could go through a much longer list, but what these all have in common, again, are really readily measured outcomes, and they're linked to effective processes. And most of these actually have been demonstrated to be effective in randomized controlled trials. There's really strong evidence for a lot of these. So I think, you know, I would conclude that the use of performance metrics for system improvement is clearly documented and in many cases tremendously effective. So how about the use for accountability with public reporting? What evidence do we have that that actually is an effective use of performance metrics? And here we get on to much thinner ice, no pun intended here, that if you look at some of the literature now, and some of this, for instance, comes from Karen Joy-Maddox, who's published extensively in this area, that if you look and try, there's been no randomized controlled trial, obviously, of this, but if you try and look and do time series studies that look at the process of care that you're trying to affect with a publicly reported measure, and ask, does that get better after the introduction of public reporting? It turns out that's really hard to show. Now, again, these are not randomized studies. There are lots of other factors involved. But in fact, what she looked at said that improvement in several of the metrics that are listed on Hospital Compare actually look like they got worse after we started publicly reporting them. They certainly didn't get better. If you look, again, at specific metrics like the use of PCI following MI, you know, she showed that actually the use rates were lower in states that had public reporting than in states that didn't have public reporting. The thinking there is that if they're not going to take certain patients for which they might get a bad grade, they'll avoid doing those procedures. If you look at, and I'm going to talk a little bit more about readmissions shortly, but the readmission rates don't correlate well with any of our other measures of quality. So the thinking is that if hospitals were, you know, doing a good job with reducing readmissions, that overall they're doing that through good quality care, and their other metrics should reflect that. And it turns out there's very little correlation there. The readmission rates, for instance, in a couple of these studies just didn't bear that out. So I think, the jury's still really out on whether public reporting, leads to better accountability. How about the notion of organizational learning? Now, this is tough to do because it's hard to define what organizational learning is. There are no real measures of what it is, and it's I think, very difficult question is whether this is true. I mean, the thinking here is that you start with a clinical problem, you develop measures to try and improve that problem, you develop systems for improvement, and as you work on that, you understand what are the limitations of your metrics, you discover other problems, and this is an iterative process of quality improvement. But in reality, what seems to have happened, and I apologize for the complexity of the slide, that is in large part intentional here. I don't know if I have a pointer here, but at least on the left, so this is a figure from a National Academy of Medicine report that on the left just listed concepts of measures, general categories in which measures could exist. And they point out there are hundreds of these. And then if you drill down on each one of those concepts and look at specific measures that address that concept, you suddenly have thousands of performance metrics. And they point out, they said, just on that basis alone, it's very unlikely that a system could, be learning if they're just flooded and overwhelmed with performance metrics. One of the quotes in this report is that the rapid proliferation of interest, support, and capacity for new measurement methods has essentially blunted the effectiveness of those. And they conclude really that, like the quote from Beth McGlynn at the beginning, that the system really isn't working in the way it's intended to promote system learning within systems. So, what's the evidence that these metrics are effective when used as incentives, particularly when they're linked to financial incentives? There's actually very limited evidence in healthcare anyway that that's the case. These are just three meta-analyses that have been published in recent years, and I won't go through them in detail. But basically, they say the evidence that supports the use of this is not strong at all. And there's very little evidence that you can improve quality through the application of incentives with a pay-for-performance system. You clearly can improve productivity. So paying people for volume does certainly work. There's no question about that. But if the goal here is to pay people for quality and get better quality at the individual level, incentivizing individuals, there's really no evidence that that's the case. So let's also ask the question about whether performance metrics can improve patient choice. The thinking here, and that's with Hospital Compare and all these websites that rate providers, rate healthcare systems, that patients will go online and look and take their business basically to the highest quality systems. So is that true? What evidence? Well, this just actually, this was an article from Health Affairs 3 years ago that took the rankings from 4 of the large ranking organizations, Leapfrog, Consumer Reports, U.S. News, and Health Grades. And I simply asked the question was, of hospitals, in this case, that were ranked in the top 10 on one of these, how many were ranked in the top 10 on the others? It turns out that if you ask, was there a hospital ranked on all 4? No. How many were ranked on 3 out of 4? 3. And look, you can see the numbers. We're talking about thousands here. How many were ranked on 2 out of 4? 85, so like 5%. So essentially there's zero agreement. And you can look also at the low performers, which is even worse. So it just goes to show that these ranking systems are inherently wrong. They can't be right by definition. And therefore, you know, how are patients going to use these systems to decide? And in fact, in surveys of patients actually do not look at these systems to make their choice. How do they find out? They ask their friends and family. That's exactly how they figure out where to go. They don't go to these websites. So I think the evidence that performance metrics are, you know, improving patient choice also is not very persuasive. So if we look at the, you know, indications and justifications for performance measurement that are typically given, I think the original application in supporting system improvement, I think that's incontrovertible, that performance metrics are key to making system improvements. But for the rest, I think either the jury's still out, like with the accountability, organizational learning, or there's evidence that it probably doesn't work in terms of incentives, all our risk contracts notwithstanding, and informed choices by patients. So I think in asking overall, is performance measurement driving high-value care? I don't think that question is fully answered yet. And despite the fact that we have embraced it, you know, so thoroughly, one of the sort of caveats here is that there is a dark side to performance measurement. And this is just one example from my alma mater here, the VA, that was published in the New York Times in 2018, and was making the point that the VA has a composite measure that's got about 50 some odd metrics in it that's known as SAIL. And all the hospitals are ranked, all 156 hospitals are ranked from 1 to 156 using this scale. And a couple quotes from this article sort of point out where the pitfalls really are here, and there are two. One are the technical flaws. Measurement, we forget, is actually a technical exercise, right? Like we would measure anything clinically or in medicine. You know, there's certain characteristics which tell us, you know, is a laboratory measurement correct or is it wrong, or are clinical measures. And so really there are technical aspects to measurement which all too often I think the measures don't adequately meet and are technically deficient, which means you're not really measuring what you think you're measuring. And this, they said, an outside audit in 2015 found that many of the scores, that's this composite score SAIL, ingredients had never been assessed to see if they were actually valid measures of quality. Hospitals could gain or lose a star solely from statistical error. And this was a big deal. The hospitals, there would be a paper, article in the local paper that, you know, their VA hospital had, you know, gone down in quality or, you know, gotten better. The other pitfall is when reasonably good measures are misapplied. And we'll talk about that. And in this case, you know, the quote was, most worrisome to some experts is the role that star ratings now play in grading performance, and it creates an incentive to conceal problems in order to collect bonuses or sidestep penalties. And I think, you know, so let's talk about what are some of the technical characteristics of the measures, and then talk about some issues related to misapplication. So actually, it's not easy to develop good measurements. Even though we have all these data, much of it's unstructured, much of it isn't terribly reliable. It's hard to define quality. If we were all to sit down and write on a piece of paper what our individual definition of quality was, I'd wager to say we get 50 different definitions here. It's hard to know exactly where and when to do those measurements. And then, in fact, in giving those measurements back to providers, it's often in a way that we're not actually sure how to take that measure and make improvements in care. And increasingly, it's becoming clear that there has to be adjustment for these measures because the patient populations that health systems take care of are so different. But if we look at, the first criterion of what's a good measure, it's got to be useful in improving outcomes. I think we'd agree with that. A measure that doesn't contribute to improving patient outcomes is probably not that worthwhile. And how do we define that? Well, it should be evidence-based. It should be transparent, that we can understand how it's measured and applied. It should relate, as I said, to some specific action or process. There should be a substantial magnitude of effect, that if we undertake that process, that we'll have measurable improvement. The burden of collecting and using that information shouldn't be too terribly great. And you need to have what I would say is opportunity improvement. What does that mean? Well, if you're pegged at 90%, and that's about as high as your system can go, really, and we've seen that plateau effect, it's probably not worth the money to spend a lot of time trying to improve that. Really, the opportunities for improvement are down where we've seen, where your system is operating at 35 or 40%, and you can see big improvements. There are also the design and the technical qualities of the measure, and I won't go through these in detail, but basically we're talking about ratios, right? There's a proportion of patients who meet a measure over the denominator of all the patients who are eligible for that measure. And the definitions for how you define that numerator and denominator, and for those who work in the measurement field will tell you that their books, their quality improvement books, have definitions of these that are pages long with the inclusion criteria, the exclusion criteria. They're very complicated. And then there's the whole issue of validity to make sure that, actually what you're measuring is what you want to be measuring. And that it captures the most meaningful aspects of care. What do I mean by that? Well, we measure, for example, we want blood pressure. We measure it not because we actually care about the blood pressure, right? We care about reducing stroke risk, reducing MIs, and we know that by managing blood pressure, we can do that. And we'll come back to that because we really want to make sure that what we're measuring correlates really well with what we want to accomplish. The measures need to be reliable. So that means when you measure it repeatedly within a system, you're going to get, if things have not changed, the same result. And that composite measures, which, because there are these thousands of measures, which are really difficult to sort of aggregate that in any useful fashion, people want to add them up and come out with a star system, right? Like hotels. You want to be able to say, oh, this is a 4-star or this is a 3-star. But that gets quite complicated, right? Because which measures do you use? Are they all the same? Do you weight them? And how do you add them up? And that was sort of the dilemma that the VA got in, was they added, 50 measures in a way that really wasn't terribly understandable or defensible. And I mentioned how the VA, ranks everybody from 156, every hospital from 1 to 156. And, that's just intuitively attractive, right? To just rank them and say, we're 82nd, or, this place is 82nd and this place is 56. And, and this is some data, again, from the National Health Service looking at hemoglobin A1C measured for one of their districts, the Tayside district. And you can see that you can take the observed to expected ratios, or I think in this case, actually, it's not even that. It's the performance. And you can see they line up really nicely, through all the clinics in that district. But if you then put confidence limits on there, you realize that actually the majority of those clinics are indistinguishable on that metric. That at the tails, they're probably, 5 or 6, clear low outliers, and maybe 7 or 8 clear high outliers if you apply 3 standard deviations. And the rest are really in the middle and not distinguishable. And star systems will tend to sort of make arbitrary and not terribly statistically defensible differences where in fact they probably don't exist and are more a feature of random variation than of true difference. And this just gets down to basic statistical principles, right? You know, you all probably remember early from some measures from basic statistics of you know, standard deviations or variances. But you know, what all these formula, all these techniques for understanding variation basically have three major components. One is, you know, how big is your signal? You know, what's the difference that, you know, actually exists? How much randomness is there? How much noise in the environment? And so the signal to noise ratio. And the smaller the signal or the higher the noise, the more you need a large sample. And healthcare tends to have fairly low signals and lots of noise. And therefore, you really do need pretty big samples. And the problem with that is that it's this, if you notice, the square root of the sample size. So you need really big samples for the most part if you've got variable measures. And then just as an example, we can look at the CAP scores, which we collect throughout this system, just like every other health system in the country, to look at patient experience. And this was recently published. It showed that if you want to get reliability at 0.9, and I was showing you 0.95, which is 3 standard deviations, what we typically all call statistically significant. So this would not even be, in our parlance, a statistically significant difference, and just slightly more than 2 standard deviations. That you need 138 patients per provider to be able to make reasonable estimates of how satisfied their patients are with them. And their argument was you really have to adjust for the patients. And if you do that, it's almost 300. Now, our system actually publishes those numbers with providers who have as few as 10 or 20 patients. And we've got to ask, is that meaningful data when we do that? I just don't think we all have a concept of the difficulty of measuring some of these. And lastly, I think, you know, we have to say, you know, if we're going to use these measures, are they feasible? They cost something, sometimes a lot to use. We need the IT support to do it. They need to be field tested in our systems. And I think one thing that's also very important is we've got to ask is the measure truly relevant to achieving our organizational goals? Does it move us forward in a way in which we want to go? So one of the problems, again, that, and this was sort of, I think, a cautionary tale that from the VA, was that, you know, overly aggressive performance measurement can lead to problems. And I, you know, the disassociation between the metrics and the processes, which I've tried to say is so important. And when that happens, actually the people who are being measured no longer have control over the process and feel that they have been lost control. There is, you know, overly strong attention on sort of the color of boxes, red and green boxes. Typically, they're the systems that have to be developed to manage the performance measurement sets are onerous, and they cost a lot. It's estimated that the U.S. healthcare system spends on the order of about $200 billion a year just managing performance metrics. So it's a big industry, and there are, you know, bazillion consultants who come in and tell you they can help you do this, and we employ lots of them ourselves in this system, just like every other health system does. There are inappropriate responses to plateauing, and I'll talk about those in a minute. And I think there is a fundamental misunderstanding of the underlying statistical principles involved in measurement. There's also, and I think the most insidious and perhaps one of the most important aspects, is something called surrogation, and I'll talk about that in a minute. And then, as I said, the employees just feel like they're not longer responsible, that, you know, the driving to sort of do their best is driven more by external factors to meet expectations. And then sometimes, you know, these are just distracting. That people are so focused on the measures themselves, they're not paying attention to other more important issues. So this issue of surrogation, and several of my slides have had some artwork on them. I don't know if people recognize the painter. Who was it, Marianne? Yeah, it's Magritte. And for those who speak French, what does that say? This is not a pipe. This painting is entitled "The Treachery of Images." And the point is that it's not a pipe, right? It's a picture of a pipe. It's not even necessarily a really good picture of a pipe. You could not smoke this, right? It's not a pipe. It's a picture of a pipe. And so he was making the point that we shouldn't confuse the two things. Daniel Kahneman, who many of you may know is a Nobel laureate who's published some recent popular books, and working with his colleague Amos Tversky, described something they called gold substitution. It's often referred to as target myopia, which, and I'm sorry to be sort of technical about that, it was defined as the tendency for managers to lose sight of the strategic constructs the measures are intended to represent, and subsequently act as though the measures are constructs of interest. So in other words, you focus so much on the measure that you sort of forget what the measure is intended to do. And an example like that might be the blood pressure measure, which we talked about. The emphasis comes on getting the measure right, green, as opposed to red. But a blood pressure of 142, a systolic of 142 is red, just the same as a blood pressure of 220 is red. And within that system, people become less interested in actually what the blood pressure is, and more interested in making sure that the measure is correct, when in fact, the real target here is risk reduction. And epidemiologically, there's a big difference between a systolic of 142 and a systolic of 220, right? But the grade is the same, irrespective. And this sort of insidious process is most likely to occur, and I would argue most harmful to organizations, when the strategic objectives are complicated and hard to quantify. And we deal with that in healthcare all the time, right? Quality of care, patient-centeredness. All these things are very, very difficult to define, and therefore, very often they get boiled down to these metrics, which I believe, you know, get surrogated. And there's evidence from a number of industries that this is a problem, not so much with healthcare or with the industry specifically, but with this whole process. So if you look at, we talked about the early experiences in education, but the same thing happened with No Child Left Behind, right? 150 years later, we saw exactly the same thing. Teachers teaching to the test, skimming, and the teacher strike in LA is, you know, in large part about that very process, that, you know, the smart kids are being skimmed off, and those schools get, or the easier kids, we'll say. There were scandals in major cities. Actually, people sent to prison in Atlanta for altering test scores in response to this. And all the while, actually, the education gap between wealthier and disadvantaged schools, which this was supposed to address, hasn't changed since 1992. You can see the same thing in higher education going on, ranking systems that have forced colleges to make investments to make themselves attractive that have absolutely nothing to do with education, fitness centers and dorms and food. And they game it, right? They invite lots more applicants to come visit than they know they can ever take because it improves their selectivity ratings. Law enforcement, and I don't have time to go through the long story of Adrian Schoolcraft, but I would recommend it to you if you just do Wikipedia on Adrian Schoolcraft. It talks about when Rudy Giuliani was the mayor of New York, they introduced a system called CompStat, which actually measured crime at the block level and was very useful because they would then direct resources to those blocks. And it was very effective in New York City in bringing the crime rate down. And the problem they had is when they hit that plateau, they kept going. And every precinct was expected to reduce its crime rates every measurement period. And what they did over time was the precinct started cheating. And one of the ways in which they cheated was they downgraded crime. So a crime that was actually assault and battery might get classified as domestic violence. So that would remove a felony crime from the, and Adrian Schoolcraft was a cop who wore a wire and recorded all of this and got persecuted and actually forcibly hospitalized in a psychiatric hospital by the NYPD. But you look at what happened in Ferguson with arrest quotas in the military. So this is from the very prestigious Army War College. I won't read through this, but their point was that they were overwhelmed with performance measures. Officers whose major sort of central tenet is loyalty and honesty suddenly were put in a position where either they were derelict in their duty or they had to lie, and they chose to lie. And made this point that this was rife throughout the Army. What about healthcare? Have we seen things in healthcare? Sort of this dark side of measurement. Well, actually, there are lots of examples. There was a measurement which many may remember from about a decade ago. There was a cohort study which showed improved survival in community-acquired pneumonia if you got antibiotics within 4 hours, and HHS put that measure in. And it turned out actually that it had a very perverse effect. In busy EDs where it takes time to get a chest x-ray and to look at a sputum and to get labs back, it was hard to do all that in 4 hours. So what do? They just slapped a diagnosis of pneumonia on the patient, administered antibiotics, and sent them upstairs. And there was, literature that came out that showed that the misdiagnosis of pneumonia and the inappropriate use of antibiotics went up as a result of this metric, and for that reason it was removed, and we no longer have that metric. But again, people do respond to these performance metrics. And you can see other examples in hypertension I've kind of mentioned. Eve Kerr's work showed that when you hit that plateau, there's a balance between over-treatment and under-treatment. And if you push too hard, you treat inappropriately a lot more patients. And in that case, it was defined as more than 4 or more antihypertensives in patients with, fairly low blood pressures. But you can see it with the satisfaction measures, nursing homes that send patients out prematurely back to the hospital because they don't want to have poor metrics. I mentioned earlier the hospital readmission reduction program, which is a big deal in every single hospital in this country. And if you look at the recent literature, there are deleterious effects of this metric. There's evidence that it's enhancing racial disparities, and there's evidence that it actually might be increasing mortality. Thinking here is that patients are being pushed out of the hospital too soon. There is a countervailing literature, which I'll readily admit to. Much of it comes from the developers of these metrics. They probably do have an axe to grind. And this actually resulted in a recent editorial in JAMA, which talked about the unintended harm that this metric may be doing to our healthcare system. One which this was this year's, Marianne? One of these was from the SGIM meeting on, SGIM last week that was presented, was showing that in response to the VTE metric, in some hospitals that have really embraced this, their rate of inappropriate prescription of prophylaxis is approaching over 65%. That's, and these are not benign therapies necessarily. They have attendant consequences. So will big data save us here? It's got some advantages. We get larger sample sizes, so that helps with the statistical precision. We can look at smaller groups now and track changes at the individual level of the patient. And theoretically, we can do good adjustment that will reduce some of the noise. But what we have to recall is that ultimately, more data is not the same as better data or good data, and sometimes actually can be pernicious in that respect. So, we always have to ask the question, are the data themselves accurate? Will, AI and advanced technology save us here? I actually think that we will get help from these systems. If they can, drive autonomous vehicles, they can help us take better care of patients. And I think if done right, this can be helpful. But it's not going to be tomorrow. This is going to take a decade or longer for developing these systems that work in ways that we would like them to. I just would like to sort of take a moment before I close to sort of actually cite one of my heroes in this story who I didn't talk about, who's W. Edwards Deming. And have people heard of Deming? Has anyone here heard of Deming? Yeah, 2 hands went up. So he is really, if you want to say who's the father of process improvement, that would be Deming. So everyone's heard of the lean system, right? Well, this is the man who invented it. He went to Toyota after the war and developed the Toyota production system, which evolved into what we know as lean management. Now, lean is widely misapplied because people don't actually go back and read what Deming said. And I think it's really important. So this is back in 1963. He said the aim of supervision should be to help people and machines do a better job. And to drive out fear, break down barriers, when you ask for 0 defects and new levels of productivity, that just develops an adversarial relationship with your workforce. And he said most causes of low quality and low productivity belong to the system and lie beyond the power of the workforce. So he actually said eliminate work standards, substitute it with leadership. Eliminate management by objective numbers and numerical goods. I mean, this is pretty radical stuff. And substitute with leadership and emphasize education and self-improvement, which is kind of the opposite of the way lean is sold these days. And in fact, he talks about the 7 deadly sins, which concentrating on short-term objectives, in this case, profit, evaluating merit reviews, performance measures, and running a company on visible figures alone, sort of the McNamara fallacy. And I love the part also excessive medical costs, which he thought was a problem in industry. And I think it just emphasizes that, we have not applied these principles necessarily in the way in which we think. And I've sat in a lot of meetings over the last 30 years talking about healthcare quality, and there's just some phrases that now always prick my ears up when I hear them, that people say, well, we've got to start somewhere. Let's just measure that. Let's not let the perfect be the enemy of the good, when what they really mean is let's not lousy be the enemy of the rotten. Let's measure, this is important, so let's measure it. It's important, but, some of these things are really hard to wrap around. How happy are your employees? How satisfied are your patients? And so, I think that, we just sort of have to be alert to what the pitfalls are. Now, I'm not going to spend any time filling out this report card for UW. That's your job. I actually think UW, based on my experience, is doing a reasonably good job in being sensible with performance measurement. There are, areas in which I would argue with, and we could spend the next hour actually going through this list and having that discussion. But I think as we all stand back, we should look at this list and say, how is our healthcare system doing in these key areas? Because these are the areas, that affect performance measurement. And I can think of examples where I think we're doing really well. I can think of examples where we're not doing near so well. But all of us are responsible, many of this room, in important ways for how we address performance metrics in our system and how we implement them. So in summary, I'd say, remember, measurements are fallible. They are not, they are approximate. And we know this in science and we know this clinically, but we forget this sometimes in quality improvement. The measures don't kid ourselves. They change behavior, and maybe in ways we don't want behavior to change. But they come at a cost, and that what we really want to focus on are the strong signals where we can measure important things. And I think just to realize that, as they say, can't fatten a cow by weighing it. The measures themselves don't change quality, and I hear everyone talk about measures driving improvement, but they don't. They just let us know how we're doing. It's confusing the speedometer with the engine. We're the engine, that's just the speedometer. And I'd say we always need to look beyond. Particularly in an academic institution, we want to focus on, what is that measure telling us that we ought to know? What do we look deeper in? And the measures should, rather than answer questions, they should pose questions more often than not. And then I'll just close with some, caveats from some famous philosophers and measurements, and I won't go through them, but making the point that measures are unreliable. They can, send us off the rails. And in fact, Campbell argues that it's almost inevitable that when we start measuring that, we're going to run into trouble from the misuse of measures. And I think we have to be really alert for it. And the famous quote that's often attributed to Einstein, but actually was from Cameron, that not everything can be counted counts, and not everything that counts can be counted. So, my view is we just need to really, not only, we got to do the measures. That's how we get paid. I'm not arguing that we shouldn't pay attention to the measures, but we need to look beyond that and ask the important questions, which I think, patients would care about. Are our diagnoses correct? Are our treatments right? Are patients getting better? And lastly, what Magritte himself said was that everything we see hides another thing. And I think that's the issue with measures. So thank you very much. And I think we have a really brief moment for questions. Sorry.